So welcome, DDU practice. The exam is in 6 weeks? Or what, 3 weeks? I don't know. Soon.
Like 3 weeks?
2 or 3 weeks? Cool. I see nods and stuff.
Yeah.
I've got nothing inspiring to say. Sorry. What I will say is that if you've worked in an intensive care unit and have a little bit of experience there, then the hardest issue you'll have with the written exam is just time. Like, make sure you get through the questions, because historically there's been a lot of content in a short period of time. So like flick through in the reading time and like just go hell for leather and set yourself time. Like, don't let yourself spend more than whatever it is, 15 minutes or so a question, or 14 minutes a question, because it gets so easy to run out of time in the written. The content is large, but it's so easily doable. And this is coming from someone that was not just not an intensive care doctor. The Viva, the time is short and it flies, and it's just like boom, boom, boom. I did the Viva twice, and even the second time, I still had technical issues at the start. Like, she gets sent this password linked file you have to open in one window, and then you get sent another Zoom link, and then like all this stuff. They do an AV check to make sure you got good enough speed, but like the actual technical logistics of the day, and then like an examiner might log in late, and then their microphone can't hear, blah blah blah. So expect some of those technical issues at the start, and when the exam is like all of 30 minutes or 25 minutes long, that could mess with your mind a little bit, but don't worry about it. It's just expected to, if it runs smoothly, fantastic. If it's a bit clunky, it's a bit clunky. The examiners are down with that. Anyone that knows Sam half decent will not be examined by Sam. You'll be examined by like the other set of examiners. They run two simultaneously. It's only Sam and at least one other person in one virtual room, and then it's Yang Yang and someone else in another virtual room. And again, they don't give much away. They're a pretty good game face. But just talk, go through the slides and talk, and you'll have control. So like, just answer whatever the question is, spurt it all out, and then next slide, and move on and move on and move on. That is a lot of content in a short period of time. That said, I will see if I can share my screen now and run through a few cases. I'll move that over to there. Now, let me open. So, can you see the like a blue screen with some DDU case stuff listed on it? Fantastic. Yep. Good. I'm just going to try and have that there so I can see two things simultaneously. Good. It's all right. Sorry, like I'm looking sideways and whatnot. All right. So what I've got here is three cases, 5 studies over 3 cases. It's de-identified, obviously. And so I just thought, these are full studies, so there's like 100 and something images in them. It's been a bit hectic here. We've been absolutely hammered with inpatient work, so I haven't had time to go through and really refine them and just pull out the pertinent images. So bear with me a little bit as we never get through them, but I thought what we do is I just start at one, and one of you can crack on from there. Just go through, tell me what you see. I'll ask you a few questions as we go, and that's it. Happy days? Expect silence to be yes. Good. All right. So all the measurements and everything will be there as you want it to be. Now, so who wants to go first? Gerhardy, I see a hand. Good man. Thank you. All right. So here's the précis for this, right? There's a lot of images, so I'll flip through some of them because a lot of it you won't need. Yeah. This is what is he? Roughly 70s, with a history of ischemic heart disease, known to a cardiologist for years, and he is coming along just for a routine scan before he sees a cardiologist. We'll have one every 6 to 12 months or something. No particular new symptoms. His exercise tolerance is a bit poor, but it hasn't changed at all. Okay, so outpatient routine study. Yep. So just tell me what you see here. Yep. You can ignore the numbers if you can't see them very well. There's nothing pertinent in those.
Yeah, cool. Okay, so it's some parasternal long with a couple of different depths.
Yep.
within the limits of the frame rate, I'm a little bit concerned that maybe that anteroceptor wall might be hypokinetic, but I'll see it in some other views. And otherwise, I think the LV size and function looks normal. There's no obvious severe valvular abnormalities, although there's a little bit of leaflet thickening of both the aortic and mitral valves. There's some color Doppler that shows either trace or mild mitral regurgitation, which is maybe slightly posteriorly directed. And I can't see anything else terrible. I can't see any significant aortic regurgitation.
What wall is this?
That's the infralateral wall.
That's good. Okay, move on.
So some zoomed images of the mitral valve.
Yeah.
That regurgitated jet maybe looks a little bit more significant than it did on the prior views, but still not sure if that's going to be mild or moderate, maybe even severe and other images, but doesn't look terrible. The zoomed images of the aortic valve, again, just show maybe the leaflet tips are a little bit thickened.
Nice.
I might be overcalling it, but there might be some suggestion of thickening at the leaflet right at the tips, especially that either non or left coronary cusp, but I'll see it in other views.
No worries. All right, I'm going to flick through a couple. That's boring. That's boring. That's boring. What is it here?
So this
So
is.
Can you see the numbers okay? So like, is it big enough to see the numbers?
Yeah, I can see them, yeah. So this is the RVOT outflow, both continuous and pulse wave Doppler. The waveform itself does not look like there's no mid-systolic notching. The pulling acceleration time is 104, which is probably reasonable with a cutoff of something like 90 being slightly abnormal. And there's not a massive difference between the continuous wave and pulse wave VTIs. So, peak velocities. So
it's not probably reasonable. It's either reasonable. It's either good or it's not good. Is it good or not good?
It's
Be
good.
definite. Good. Fantastic.
Yeah.
Good. Thank you. What if his heart rate was higher? Does heart rate change your expected acceleration time?
Yeah, definitely. So with heart rates, that as your heart rate goes up, your pulling acceleration time will definitely come down, and it's heart rate dependent.
Good.
This person's heart rate's it's 90, 96 or something. So
bored with that now. Moving on. Where is what I want to see? Oh, here we go. Good. What do you see here?
So this is parasternal short axis at the mitral valve and papillary muscle levels. There is some color and color compare images. I can't see a lot of regurgitation on that view. I can see the leaflets are moving okay with normal motion. On the papillary muscle level, I am concerned about that.
I get the first good play again.
Yeah. I'm concerned about that anteroceptor wall being hypokinetic, maybe even akinetic. Other walls, maybe the infrareceptor wall is also hypokinetic, but a bit hard to see. The other walls look like they're moving okay within the limits of a bit of a low frame rate. Sorry.
That's right. So from what you've seen so far, what do you think the ejection fraction is? Or systolic function is? Let me put it that way rather than giving you making you forced to say a number. Normal, mild, moderate, severe.
Maybe mildly impaired.
Yeah. Okay. Let me just cut to the next one. Make a play. All right. What do you think of that?
Just right down at the apex.
Yeah.
I think that function here looks relatively normal. I don't think there's any severe apical dysfunction here that would be like LAT territory stuff or Takotsubo's. I think that looks okay.
Yeah. Okay.
All right. So this is an apical four-chamber view. It looks a lot more abnormal than the other views did, to be honest. I think that's because we're looking at more of the septums. That's the infraseptum and the anterolateral walls.
Very nice.
The apex looks quite, I'm a bit worried about the apex. It's not moving much at all on this view, at least. It's a bit different to that short axis that I saw. And I'm worried that I can't see it very clearly, and there could be something like a mass or a thrombus there. Otherwise, the mitral valve looks like it's moving well. The right ventricle looks like it has normal systolic function and probably has normal size, at least compared to the left. The left atrium looks, I think, moderately enlarged, and the right atrium is probably mildly enlarged as well. I think the LV systolic function is moderately impaired. Yeah,
given this LV function, would you be expecting or not expecting to see an apical thrombus?
I think given that I can't see much movement around that, especially the sort of apical area and the apical infrareceptor wall, I'd be really worried about a thrombus in this person. And I'd really want to exclude it as much as I could.
What else could it be?
So I mean, it could just be the shape of the LV. It could be like a, you could look at the sphericity index of the LV. It's probably pretty unlikely to be a tumor, but there are invasive tumors, especially melanomas, that can invade the LV apex, and things like non-compaction are very, very rare, but still come up as a differential. It could just be artifact. It could be near field clutter, making it look like I can't really see much there.
Nice. I guess theoretically, could it be any sort of infiltrative stuff? Could it be eosinophilic?
Yeah, for sure. Yeah,
possibly.
Apical obliteration.
Yeah, you get case reports about that. All right, skip through all this because it's all boring and not relevant for now. There. Do you think it's thrombus more? Do you think it's more or less likely to be thrombus now? More or less.
Look, I think I can't see the actual thrombus itself, but given the structure that I'm seeing, which is this is like an RV focused view, and there's aneurysmal.
Keep faffing, sure. I'll make excuses.
That absent movement of that septum, especially how it looks aneurysmal, makes me very worried about a thrombus, although I can't see it.
What about now?
Again, I can't see it for sure, but there is something in that apex that doesn't look normal.
What about now?
And then there's this aneurysmal portion of the septum.
Yeah, I think so. Back here, I think we've got some endocardial dropout here. I think there is a bit of this prominent septal knuckle. I'm not sure whether I'd say that's. I wouldn't probably say that that's aneurysmal. I think it kind of holds slightly abnormal shape, but when you say aneurysmal, you got to be cautious of the implication, the potential that we're going the wrong way when it's during systole, right?
Fair enough.
But I'm not sure that it is. If you come around here, what do you think?
I mean, this is, I can't see anything on this view that would look like a thrombus. Maybe it's a little bit more reassuring than the other views that I saw.
What do you think this is?
I'm still. So it's either going to be that the adjacent areas of endocardium are really thinned, and that's just normal endocardium, or that's going to be something like it could be a laminated thrombus, I suppose.
What are you going to do next?
So I would do off-axis imaging and put color on to see if that.
Here you go.
Yeah, so this is some color imaging with the scale reduced down a little bit that shows that color doesn't cross whatever that is. It still is not super clear to me if that's a thrombus, like a laminated thrombus, which should be high risk for, or just the endocardium. But it's unusual.
So what are you going to do next?
So there's a few options. If I was doing a study at Nepean, I'd probably do a contrast echo. It could help me delineate that mass. These pictures look a little bit nicer of that apex, and it just kind of looks like there's some trabeculations, but it looks a bit unusual.
Yeah. Okay, well, you're at Nepean.
So a contrast echo. The other options would be things like a TOE or a CT or an MRI is the gold standard.
Would a TOE help you?
Thrombus. Sometimes it can. It's usually not great. But if you've got terrible images, then sometimes you can see. It's just quite far in the far field, so it's hard to see.
Yeah, exactly. You can have, and you can just miss stuff still, right? It's hard to pan through the apex sometimes. All right, I'll go through some of the apical images. Sorry, the contrast images now. So let me just go to here. All right, so this is prior to contrast injection. Yeah.
Yeah. So I see it looks very similar to the prior images that we saw, where up in the apex, and this is a apical 3-chamber view. So that's the anteroseptum. It just looks a little bit unusual, to be honest. Like the mid portion of that anteroseptum, whether it's dropout or if it's just very thin.
Through here,
there's this structure, I guess, closer to the apex that is what we're concerned is a thrombus. I'm not sure if this helps me much more. There's definitely hypokinesis in that area.
Here's the contrast.
Oh, crap. Okay, so it looks like the contrast opacifies that area that I was trying to look at before. And so that makes it less likely to be a thrombus, and maybe it's just dense trabeculations that I was seeing, or some sort of just can't think of the word. Artifact.
Yeah, nice. And you can see how much I think that this shows a few things really nicely. First of all, well done. So yeah, poor LV function, a funny, like almost almond-shaped thing sitting right up against the wall. That you've got to think of this as being an LV thrombus and Nepean otherwise, right? It did. I agree. It looked laminated, and put money on the fact that this is going to be a thrombus. So I reported this study yesterday, and I said this person got an LV thrombus and Nepean otherwise, and then they got a contrast study in the afternoon because it's Nepean, and we're fortunate and lucky, and someone else is paying for the contrast. And this is what it showed.
Yeah.
And then the cardiologist that supervised the contrast study messaged me and showed me this and said he was certain as well this was going to be a thrombus and was very taken aback by the fact that it opacified with the contrast. And I think this, another thing just bear in mind is I think that this shows really nicely, like, we think that we know where the endocardial border is, right? Like, we draw out Simpsons all the time and we think, oh yeah, cool, that's where it is. But it's actually, it is not where you think it is so often. We're really bad at it. Even with good quality imaging can make it a bit easier, but you can see how, thin this portion of the wall is through here, right? Like, I've got some contrast coming through, but you can see it's not thick and it is certainly thin, right? And is this just some funny tuberculations or not? This looks like it's, whilst the study wasn't like done in the perfect like set of steps for it, like we don't have a good flasher or anything here, for example, but you can see how this septum, this portion right through here is just really dark. It's completely dark, whereas up here you can almost see like some speckles within it. You got to wonder, is this delayed contrast filling of the myocardial, the endoepicardial vessels that we've got going through the coronary arteries and filling this? So in other words, this is still functional myocardium or vascularized myocardium, and this is dead scar stuff, and that's why it's thinned. I mean, maybe, don't know for sure, but it's a possibility. But yeah, this ends up being a contrast low, so not an aneurysm. Sorry, not a thrombus.
Interesting.
Good one, I thought.
I'm glad I hedged my bets.
Yeah, well done. It's soft though, and in the exam, I'll tell you where to hedge them to. Don't hedge your bets. Be definite it either is or it's not, and then you want more imaging and all those things that you said. You want off-axis imaging. You want to use color Doppler, drop the scale, maybe move your like focal point up, go through it in multiple planes, use X-plane if you can. All those little things. And it's amazing that you can find a thrombus where there was nothing on standard imaging if you've got a high enough index of suspicion, right? Really poorly functioning LV. All right, next study. So, who's next? This one has a transthoracic and then a toe.
I can give it a crack.
Nice one, Drew. Cool. So this is a elderly chap. He was about, I want to say, in his late 70s, who has a history of known mitral regurgitation, and he presented to the emergency department after having had a fall when he was climbing over a fence. It was unclear whether he had true syncope or not. So whether he actually blacked out or not is not quite clear. And this is his study, okay?
So I guess Keith, and presumably a history of a cardiomyopathy in the past.
He has no.
No, okay, so new finding.
Just his mitral regurg is known, but nothing beyond that.
Great. So I guess the left ventricle on linear measurements appears to be within the normal range. But I do take that with a grain of salt. The left ventricle does appear dilated. Supportive of that is some tethering of the mitral valve leaflets. And it looks like the posterior leaflet, based on this imaging, is more so, which is in keeping with the posterior directed mitral regurgitation that we'll have to quantify properly on further imaging. The aortic valve has good leaflet excursion, doesn't appear thickened. The aortic root visibly appears normal, and the right ventricular outflow tract isn't dilated, and radial contractility appears preserved.
Nice. So from what you can see so far, acknowledging it's only one shot, like one, window so far, do you think this mitral regurg is mild, moderate, severe?
Yeah. Yeah, one shot could be very eccentric. Can't see the vena contracta. It's at least moderate,
Yeah,
I'd
good.
say. I should mention that the left ventricular function appears at least moderately reduced as well in these images.
Yeah. Which does what to your MR assessment? Like how does that affect your interpretation?
Sorry, say that.
How does that affect your interpretation?
Of the
Of
MR,
left-
well,
Yeah.
so I guess if I'm performing continuous wave Doppler, the velocities may be reduced. If the left ventricle is dilated and there's high LVEDP, it'll make my mitral regurgitation look greater, at least from a color perspective.
Look greater. So if your LV function, sorry, I just want to make sure that I'm interpreting correctly what you're saying. If your LV function is crap, will your MR on color look bigger and brighter, or will it look like less?
Yeah, I guess I'm not sure. Yeah, I'm
So
not sure.
it will look, assuming you haven't mucked around with your color scales too much, it will look worse, right? So if you've got it will be less prominent and you'll undercall the MR. So if your LV is crappy, you're not gonna have the pressure gradient from left ventricle to left atrium, so your color flow will look smaller. Does that make sense?
Okay. Yeah, I guess presuming the LA pressure is high, that there's less gradient between the two.
Yeah. So even if your LA pressure will be high if the MR is bad enough, of course, which doesn't take much, but you're gonna have a reduced LV pressure, so your LV LA gradient will still be less, even allowing for LA being whatever it is. But you will have a less impressive looking, therefore potentially you'll interpret as being less severe MR. That makes sense.
Okay.
Cool, nice. All right. So yeah.
So moving on, I guess there's a small pericardial, localized pericardial fusion along the inferior lateral wall.
Yeah.
There's leaflet underwriting of the anterior mitral leaflet with posterior directed mitral regurgitation. There is a flow convergence zone. The vena contracta at 60 doesn't appear significantly large.
I'll just see if we've got a better shot of it. Maybe we don't. Yeah, doesn't look massive, does it?
You can measure it 2 or 3 maybe.
Yeah.
But it might be under assessed with that degree of eccentricity.
Yeah,
it's just some
right.
trivial anterior directed aortic regurgitation.
Yeah. All right. I'll flick through. Ignore that. Don't care about that. Here. Is the tricuspid regurgitation relevant to your assessment? The other thing is MR, right? So is the TR relevant at all?
Yeah, I think that significant mitral regurgitation and left ventricular dysfunction is a common cause of pulmonary hypertension, which would increase the pulmonary pressures and the severity of the tricuspid regurgitation. However, this appears to be relatively lower pressure, Vmax of 2.6, max gradient of 27.
Yep. And in terms of further assessing his MR, like you already mentioned a few things, vena contracta and like some flow convergence zone, that sort of stuff. What else do you want to know for the MR? That's where the MR. Yeah. So what else do you want to know for his MR?
So we assess the 2D features of the mitral valve. So you look for flail. You look for a non-coaptation 2D defect. We talked about the color. Continuous or pulse wave Doppler through the inflows might show a E wave between 1.2 and 1.5 in height.
Yeah, nice, good.
You would look for a mitral continuous wave jet that might show a V cutoff sign. This would be tricky given the eccentricity of the jet. Mm-hmm. And then you can perform pulse wave Doppler through the pulmonary vein, looking for systolic reversal.
Nice.
In true organic mitral regurgitation, I think you can do a VTI ratio between the mitral valve and the aortic valve as well. I think 1.4 is the cutoff.
And then you can do your other quantification methods, right?
Yeah, you can do your effective regurgitation orifice area, your regurgitation fraction, regurgitation volume.
And how often do we do EROA or PISA in real life?
Well,
nowhere near as often as we should.
That
Is the
depends
answer.
on which hospital you work at. The
Yeah.
guidelines would say that all moderate lesions should be evaluated, but probably not common. And there's, in this particular case, we might underestimate the PISA, so we might have to look at volumetric methods
Nice.
to quantify it further.
Yeah, because we've got that eccentric sort of hard to gauge jet. You can angle correct. Most in the formulas being able to angle correct for the for your like PISA dome, you can sort of angle correct for the flow with which it's going into that, which is just adding on more potential sources of error to more potential sources of error. But you're exactly right. That idea of you assess someone's MR looking at their two-dimensional features, the color flow Doppler, pulse wave Doppler, continuous wave Doppler. And you then sort of go, all right, is this mild or is this severe? Those two sort of declare themselves. And there's a big gray zone. We're like, how moderate is moderate? And that's when the quantification methods come in by the ASE guidelines. I think that we do them occasionally. I think that by the books, we should be doing most labs should be doing them more often than what they are, but they are like time consuming. And if you're reporting 20 studies in the morning and 20 studies in the afternoon, to have the sonographers do it and then to go through and to check it, make sure the images are appropriate for what you're calling, does get complex. And so I wouldn't say we get lazy. I'd say the workload outweighs the capacity to do it, and that some of us are lazy. All right, good.
Okay, so this is these images indicate a significantly eccentric posterior directed jet. It is moving the posterior wall of the left atrium. The jet is not completely dense, but there's a clear envelope still fitting within the moderate range.
Yep, nice.
The peak velocity is 5.7, which is surprising in the context of the severe LV dysfunction.
5.17, yeah.
Yeah, so it's not 4 or less. The PISA, I guess visually doesn't appear to be in the 0.9 to 1 ratio. Oh, sorry, you did do it. Aroa 0.4, regurgitation volume 70. So yeah, I guess that would be in keeping with severe, with a cutoff of 0.4 centimeters squared and the regurgitation volume over 60, sorry.
And does this fit everything else you've seen, or do you think this is making it look worse than what it actually is?
I should probably step back and say it doesn't look like a particularly suitable measurement. And this is one of the drawbacks of the PISA method.
Yeah. All right. So someone has attempted to place a pulse wave cursor in pulmonary veins. How well can you see that? Probably not very.
Pretty tough. The sample volume should be inserted about a centimeter deep into the pulmonary vein if you're able. Interpretation is challenging, but I'm not seeing any indication of systolic reversal in this case.
Yeah, and here's where they put the cursor measurements. From the ECG, it's probably systole and diastole, but it's pretty hard to see. All right, so if you need to further assess this man's MR, what are you going to do next? Because if you're going to call it severe, he's a previously well-functioning guy who's got LV dysfunction and severe MR, right? And so that has potential implications on his management. You should think, should I be fixing it now?
I think I probably would step back and say it's looking more moderate. It's not seeing severe MR personally, but a transesophageal echocardiogram would be a next good step.
Fantastic,
you can
good.
MR or CMR as well, which is pretty good for volumetric assessment.
Yeah, you're right. Gold standard, right?
Yeah.
For the volumetric stuff. All right. So here's this punter's toe. Do you want to keep going, or should I hand the baton over? I've only got one other study to look at after this.
Yeah, I can keep going or whatever.
Yeah, go for it. I mean, it doesn't bother me.
It doesn't add a whole lot. I think we're still seeing leaflet tethering. I think we're seeing the anterior leaflet underriding the this restricted posterior mitral valve leaflet.
I'll just flick through, I'll scroll through some pictures for you. So you see how much nicer you could potentially do your volumetric assessment here, right? Like get a picture on that.
Yeah, and even here, look, the PISA doesn't look significant. The flow convergence, the vena contracta, at least the color assessment still doesn't impress me, I guess.
Yeah, nice. All right. The measure
MR radius 0.5, it's moderate. Yeah.
Yeah, let me keep going. Let me keep going.
Multiple jets makes the PISA method non-suitable or unsuitable. It'll underestimate.
Yeah. Is it true multiple jets, do you think? Or are we just catching
Bicomissural view?
Yeah.
I think there are, if you look in the bottom left, there are 2 jets, but yeah.
Smidge in there, right? Yeah. Okay, let me keep going. Here. What view is this?
So this is the long axis view, 120 usually, 113. You're looking at the A3, A2, and P1
Nice.
in this particular view, leaflets on this one. Well, I'll tell you.
Does it look normal or abnormal? The valve, purely looking at
like I said, I think the posterior mitral leaflet, posterior mitral leaflet looks like a small. I want to say aplastic, but it's not. That's not the term.
Yeah, hang on, I just want to see. So let's go through it frame by frame. What's that?
Yeah. So on the atrial side of the A2 segment is a small mobile structure. Look, it all depends on the clinical context in this particular patient. It wouldn't be uncommon in a 70-year-old gentleman to have some degenerative changes and would probably be the most likely differential within the clinical context. Other differentials are infection. Thrombus would be considered less likely. Endocarditis, but morantic in the patients such as antiphospholipid syndrome, and rarely malignancies, benign malignancies. But I'd favor degenerative in this particular clinical context.
All right. We're doing a toe, so what else do you want to look at?
So one of the criteria for severe MR is systolic reversal in the pulmonary vein. This performs a pulse wave through the left superior pulmonary vein, and we're looking for systolic reversal. Yeah. So
will systolic flow reversal be above or below the baseline if it's flow reversal?
Systolic flow reversal would be below the baseline.
Good.
So this is a bit tricky.
So you think systole starts about here?
Yeah, it's kind of biphasic, isn't it? I think that's probably a bit of artifact. I think if you look at the next cycle, you have your S and your D. So I think there's systolic blunting, which would be in keeping with moderate. But
so S, D, S, D.
Yeah.
And what's this?
Yeah, I'm not sure. It could be systolic reversal. It's kind of mid systolic reversal, but looks unusual to me. And this is
Yep.
And this is a pulse wave through a pulmonary vein. I'm not sure if it's the right upper pulmonary vein. and just some SD
Yeah, so
blunting there.
yeah, very nice.
Seems to be.
I didn't do this study. It looks like they've swung around to the right. But it may have been chasing the left lower and just had a funny angle. Because here I suspect they've gone round to the right, back around 0 degrees. All right, what do you see here?
So again, not the best trace, but if that particular one doesn't look too reliable to me, I'd look at the next, and I'd see that there is an S and a D wave as well that are above the baseline, keeping with slight systolic blunting.
Yeah, nice. All right, I'll just flick through. All right. Is this coming through okay? This can be a bit clunky because it's 3D.
Yeah.
So you still think it's, would you say it's moderate or severe MR now? Moderate or severe? I don't know what you're up.
I'm going to be honest. I don't use a lot of 3D to quantify.
Oh, sorry, prior to the 3D, prior to looking at these, like.
I think overall I'm still thinking moderate.
Yeah. I mean, I don't do much 3D either. I'm still learning it. So I'm very much amateur at it. But I'll go this one where there's no color just to make things less clunky. What structures? Can you recognize any structures here? What would the anatomy be?
Yeah, so at the superior portion, so looking at the mitral apparatus, and that's the anterior mitral leaflet at the top, but the superiorly, and the posterior mitral leaflet below. Yeah.
So we typically, for those that don't do much 3D, and so I don't do much at all, but we're trying to bring it more and more into practice within our lab, especially when looking at valves or prosthetic valves or structures of any sort, to try and get a better idea of how things are sitting in time and space. We typically try and arrange it so when we're looking at the mitral valve, we have the aortic valve at 12 o'clock. That's sort of the standard convention. And then you can work down, so you got your anterior mitral valve leaflet, your posterior mitral valve leaflet, and your aortic mitral curtain and other structures from there. You can see, I think what some of the nice things about the 3D imaging, that can show you just that size differential between your anterior and posterior mitral valve leaflets. Anterior is massive and chunky, posterior is far less so. And you can see that the way they sort of collapse together, like posterior and anterior sort of flick open and close like that, big and this is small. I think, again, your resolution may not be good enough to appreciate it, or the frame rate, but you can see that little flapping thing then that we could capture on the 2D transesophageal imaging in through here. It's just this little like finger-like projection that flicks in and out through there. Could be a ruptured secondary cord as well. Was another thought about that structure. I don't hear that thing.
Okay.
Yeah, was the thought at least.
But you'd think the jet would be anterior, wouldn't it? If you thought it was the cord.
Yeah, this is a good question. So that was what I asked the cardiologists,
the apparatus.
And they said, like the cord itself could just be like, may not be particularly contributory to the mechanism of the MR, but is instead just something we're seeing. So they've gone chasing this again here. SD. All right, now so we've got moderate MR, severe MR.
I'm going to steadfast with moderate.
Nice, good. Would you send this guy for a valve replacement?
No. And particularly, like he seems he's asymptomatic. He just jumped over
fell
very,
over.
Very active, presumably jumping over fences.
Very active, but his LV is a bit down, isn't it?
Yeah. We can, he's NYHA1.
Yeah, nice. I love it, and I laugh. I have a big laugh because I didn't do this toe. I did a toe on this guy though, like a week or so prior to this toe, to assess his MR, and I had similar but less pretty pictures to this overall, and I said that in the pictures that I had, that secondary cord phenomenon looked a bit more prominent, no prolapse. And I said, similar to you, I said in the context of, LV dysfunction, I'd be concerned that this is actually potentially severe MR. When I did the toe, his blood pressure was 90 to 100. Remember, systolic blood pressure really important. Assessing was MR. So I said in that setting, like maybe he does have severe, just undercalled it based on his hypotension from the sedation agents for the toe. But interesting, and so I had a similar, almost the same pulmonary vein flow profile, and this is why I put this case up today, because when I looked at this and had a look around, I had a chat to a couple of people, I said I think that this is not flow reversal. Where is that? Yeah, you find it. But one of our imaging cardiologists said no, definitely it's biphasic. It's flow reversal. Said this is flow reversal in the pulmonary veins. It's just it's a biphasic pattern. And they only found, so the person that did this toe, examined all 4, only found in 1, but said no, this is biphasic systolic flow reversal, just seeing in the latter half of systole. Which when I think of things like much about prolapse, I think of biphasic. You can have a late systolic, systolic MR, and you only see it in that second half of MR, and that prolapse sort of kicks through more. But they confidently call this as some systolic flow reversal, again, which I haven't seen a case like this with that pattern before, but it shows it's possible. But all the other components, Gerard said exactly the same thing as you, and I interpret it the same way. And my understanding of the discussion that happened in the cardiology meeting was that this ended up a bit of discussion amongst them all, and they end up saying, given he's well, but his LV is going down, it's gone off for a valve. That's why I have a laugh, because I did exactly what you did. And then some cardiologists came along and said.
So did they think that it was severe, or did they think that it was moderate with a bad LV and maybe some? So
more the latter, with the exception of that pulmonary vein, that single pulmonary vein profile. All the other parameters, color and venous tract and all that sort of stuff. Yeah. Going by the books and more towards moderate, like it's at the bad end of moderate, but still moderate. Yeah. Okay. Anyway. Last case, it's another toe. Rishi, you may know this one. Or maybe. I can't remember if you know this one or not.
No, I'm not doing exams, so Rob can go ahead.
Right, okay. Rob, leaves you stuck with this. Okay. It's these crappy pictures that I took. I apologize for that. But let me give you the backstory. Sure. So this is I think she was in her 60s, and she had a valvular surgery. I won't go into too much detail. She had a valvular surgery performed at our cardiac surgery referral hospital about, I think it was 2 or 4 weeks prior to this study. Okay, so she had a cardiac surgery, had the surgery that went uncomplicated, discharged home. She had a toe after her surgery, which we don't have access to, so you can't see those pictures. And then in the day before she presented at night. So that day she developed chest pain and some breathlessness. ECG, no ECG changes, no clinical overt heart failure, but ECG change, but chest pain, breathlessness in the setting of having recent cardiac valve surgery. Transthoracic echo, she had that, and that is non-contributory to what we will see here. Okay.
Okay. So I guess we're starting with, it looks to me like the transgastric short axis views.
Nice.
And given the history, I guess I start with LV function, which in the limited frame rate that I can see appears preserved, although if this is off axis or not, I'm sure they're not sure, but there may be a D shape to the septum. And then I guess anteriorly, it looks like there may be a small pericardial collection, although I'd like to see that.
Is anterior at the top of the sector or the bottom of the sector?
Bottom of the sector is anterior.
Yeah. Nice, good.
And it looks like there may be a pericardial collection, although I'd like to see that in other views, given that she's post-cardiac surgery, she could have a loculated collection there. That's explaining it not being circumferential.
So what region is this through here on our segment? What segment is this?
So where your mouse is, that's the anterior, and then sort of to the right of the screen is the anterior lateral wall.
Yeah.
And we're sort of going between the base and the mid-papillary level, depending on which part we're in. But when I can see it's more towards the mid-level.
Yes. And what do you think of that septal movement? Do you think it's moving normally or abnormally?
I think it's moving abnormally, although you have to be cautious interpreting that post-cardiac surgery, because you can have abnormal septal motion post-cardiac surgery.
Very nice. And what do you see anything else? Ignore the right heart, by the way. Not interested in that today, which is a very un-Nepean thing to say. But
I guess looking the inferior septal, maybe inferior and inferior wall looks more towards hypokinetic.
I wonder if we're just a bit off axis there.
Yeah.
All right, I'll move on. Let me find. Yeah.
Okay.
What is it here?
So this is still transgastric, but we've swung around now to 50 degrees. So not quite far enough, I guess, to get, it's not far enough around to be doing a 2-chamber, or a long axis. This is, not sure what you're trying to show me here. I guess we're doing some X-plane imaging as well.
Can you see anything in the LV cavity?
It appears like there is something within the LV cavity, more towards the inferior wall, which is sort of independently mobile. I'm not sure what that would be. I guess it could be artifact, although, so I'd like to see it in other views. It does appear to come in the X-plane image as well.
Got an X-plane down one there, yeah.
Yeah, I can see it. So it is in that. I guess other differentials could be whether there's been a injury to the papillary muscle, so I'd like to interrogate the mitral valve, or whether there's a thrombus.
So she's 4 weeks post cardiac surgery, presented with chest pain, no infective symptoms.
Yeah,
chest pain, and not in failures. Her blood pressure okay.
Yeah. I guess being post surgery, it could be foreign material, whether they've left an LV vent or something in there, but that would be unusual.
Suboptimal.
It would, not ideal.
not ideal. Yeah. All right. Good. Yeah, that's exactly what I wanted you to notice.
Yeah.
All right. Now let me come around to here.
Right. So this is, we're now at the mid-esophageal views. And so it looks like she's had her mitral valve replaced. There's unfortunately a lot of shadowing artifact on the anterior lateral side. It appears to be a stented biprosthetic valve that's been put in.
And why do you say that?
If it was mechanical, there'd be more shielding artifact below the valve.
Yeah, good.
Yep.
You see, if this was all metal, you'd see very little down here, right?
Yes, exactly.
Yeah, and you can see how beautiful, like you've lost this. It's fantastic. Yeah.
Yeah. It looks to be coapting fine. I'd like to put some colour across it, make sure that there's no paravalvular regurgitation. But it doesn't appear.
Do you expect any by default?
I don't expect any, not in this type of valve. And being bioprosthetic, there shouldn't be washing jets, etc. It should just be appear like a normal valve.
What's that?
So I mean, the image rotates a little bit, but depending on the height, sometimes you can start to see the beginnings of the LVOT if you start to get a 5-chamber view.
Yeah.
But otherwise, that should be the inferior or towards anterior septal wall. Sorry, he's showing me a few images now.
I've scrolled back. Sorry, I've moved on. Let's do this.
All right, so now we're at the mid-esophageal 3-chamber or long axis view. Again, the mitral valve appears to be coapting well. And then it looks like there's also been an aortic valve replacement.
Nice, good.
So there's lots of shadowing artifact below it. And I imagine it's also going to be a stented bioprosthetic aortic valve replacement. Otherwise, I'd expect reverberation below it if it was mechanical.
What's that?
Can
you still see a structure within the LV?
I can, yeah. That structure is there, which is if it's in that position as well as where it was earlier, which was more inferiorly, then that's concerning. That's highly mobile. And I'd be concerned, like we talked about before, whether there's some sort of foreign material. It'd be unlikely. She's not had any infective symptoms to be endocarditis.
Yeah.
All right, so we've got some...
So I'll just give me a second to find what I wanted to find. Sorry, where is it? Yeah.
Okay, so we're explaning across the mitral valve at the moment.
Yep.
And so on the left-hand side, that's more towards the long axis picture. And then I guess we're 90 degrees from that. Again, stented bioprosthetic mitral valve. On the image on the left, I can see that structure again that appears to be independently mobile. I'm not sure what that would be, but it doesn't appear attached to the valve. It appears to be more freely moving within the ventricle.
And then what about on the right?
Again, you can still see the same independently mobile structure within the LV. I guess it could be, just thinking about other options, is whether on dissection of the old valve, whether they've left some chordae there with attached papillary muscle or something. I'm just trying to think of other things that it could be within.
If it was chordae, would you expect it to look like that on echo? Like if it was tissue?
No, it looks probably more hyperechoic than that. So again, something foreign, some sort of foreign material.
You see down here, right, as well?
Yeah, exactly.
So there, something flicking in there, something flicking there. So really, like the last question now, the most important question. You've just done this toe on a woman that had cardiac surgery 4 weeks ago. She got chest pain and you're not in a cardiac surgery centre. What do you do?
So I need to call back our cardiac surgical colleagues and probably get her transferred back to a cardiac surgical centre, given we're concerned that there could be foreign material within the heart and the risk of embolization and causing problems like stroke or ischemia would be my concern.
Yeah, good. And that's the crux, right? It's like whatever this is, it appears to be potentially free floating within or at least partially attached within the LV. It appears too echo dense to be just tissue, and what it is looks to be foreign material of some sort. Chest pain, who knows? Probably unrelated, maybe not, maybe is. But if this thing flicks off and it's a foreign body, that is just going to go straight to the noggin, right?
Exactly.
Or get caught in her, as you assessed her prosthetic aortic valve, and if that got caught in her prosthetic aortic valve, it could very well just jam up the valve.
Yeah.
Which would be a pretty quick way to go into pretty profound heart failure, I would imagine.
Yeah.
Or if it went backwards and flicked into the prosthetic mitral valve, like the stent to mitral valve, like that flicked backwards and got between the leaflets of the mitral valve. Similar thing, right?
Yep.
Yeah, nice. Good. So yeah, it's
Did she
weird.
What was it? Did she
Good question. So I had a couple of other people come in while I was doing the tour to get second and third opinions because it was weird. And then I would chase the surgical notes. And so what we ended up saying in the report was that everything like you've described, on some of the other images, like, there's no color flow. Like, it doesn't cause perturbed color flow in particular. You can clearly see it. It is visible on a transthoracic. It's clearly visible on a transthoracic, and it looks like a little filamentous fiber thing that in some views looks to be attached to the mitral valve, but just free floating in the LV. Apart from that, like one end tied down, one end floating. And the end outcome was can't exclude, whilst it doesn't look like thrombus, got to consider it. Clinically doesn't fit with effective endocarditis, but you've got to consider it. Most likely thing is it's a remnant in away from surgery, whether it's deliberate or accidental, don't know, because we don't know what the surgery was at that time. No one had the surgical report. No one chasing that, and the patient had a neocord as part of her mitral valve, which I don't understand the indication for doing that or not. Maybe someone can enlighten me why some patients get a neocord and some don't. I don't know. But after learning that and then reviewing the images again with some cardiologists here, that there was perhaps this is potentially a ruptured neocord. So that was there and there's now one end is broken off. Yeah. So artificial material and what was presumably attached to 2 points within the heart is now only attached to one, which is why it looks like this strand. My first thought when I put the probe down was it looked like a suture. It looks just like a suture floating around, right? But its point of attachment wasn't clearly associated with the mitral valve apparatus or the aortic valve apparatus.
Yeah.
Does anyone know why they do neocords?
I mean, I've only ever seen neocord in mitral valve repair, not in replacement. I'm not sure what the others think.
Understand.
Like an attempted repair and then a replacement, maybe. I don't know. I'm not a surgeon. Not yet.
Yeah, so interesting case, right? But it's that, what do you do? Because that's sort of the point of the DDU Vivas is you got to pick what's wrong, but then if you got more importantly is what you do clinically. And so yeah, that was for me, because I did this TOA, was get a second opinion because I don't know what the hell I'm looking at. This does not make sense to me, and then work backwards from there. Patient safety being number one, if it's an emergency or not. Yeah, nice. I haven't, because it's a few weeks ago, I haven't gone back and seen what the end outcome of her was. Like, I don't know what happened after that. I should look at that up one day, probably soon, actually. All right, so that's all the cases I had. This is meant to be Santosh and I, but he got called to the cath lab for a STEMI, which is why it's just me. So I don't know if his cases, but it's 3 o'clock anyway. Any questions? Not that I'll be able to answer them, but I'll do my best.
With the first case, Ben, is that in the same location where you might find a false tendon on the?
Yeah, nice, good question. Yeah, absolutely, it is. And I see them more than I expected to, or more than I thought I would. Now I've started doing a lot more reporting. The only thing about a false tendon is if this is your LV cavity, like seeing through here, where this thing, like, it appeared more towards one, like the septum side, like almost like it was stuck on now, allowing for not being able to see through there. It looked like it was sort of stuck that way. Hang on, draw. So, make both amazing viewing on YouTube, I'm sure. So now, how can I do this? I'll do this backwards. So this one is what it looked like on the study that she had, right? It looked like this sort of thing that's a bit lateral, but towards, sorry, I say lateral, I mean towards the septum. Whereas a false tendon, I've typically seen running a bit more perpendicular to the gun barrel of the LV. They do look like that, and it's just like a bright linear structure. So it's definitely a differential.
Yeah.
Or is this a thrombus or not? Is it a false tendon? But we should almost always, get color flow around it and all that.
Yeah.
Best luck, guys.
Thank you so much.
See you next week.
Thanks, Ben.
Thanks.
Thanks.